Hello, everybody, and welcome to Southeast Orthopedic's virtual seminar. I believe there's a few people clicked on. I know at least some of my family are here. So at least I have 2 or 3 people in the audience and hopefully a few more. We've been doing this now for the last year. We've had a very good success. Hopefully lots of people will learn something interesting, and we'll go through a talk answering some of the top questions that I hear in my practice constantly from my patients. We then have a connection that you can write questions in after the talk. We'll go through the questions and I'll answer them for you, as many as we can in the time allotted. So welcome to the seminar. Hopefully everybody's comfortable at home, and I'll get started. So my talk tonight is going to be the top 10 questions that patients ask me about total knee replacements. And my name is Dr. Gavan Duffy. For people who don't know me, as I said, my name is Gavan Duffy. I'm a total joint replacement specialist at Southeast Orthopedics. That means my 2 operations that I perform are hip replacements and knee replacements. Today, I'll be talking about knee replacements primarily. A little bit about me. I may have a slightly strange accent. As you can see from the flag, I was actually born in Ireland, raised there, did my medical school in Trinity College, Dublin. Was lucky enough to get into the orthopedic training at Mayo Clinic in Rochester, Minnesota for 5 years. Did my fellowship training at Harvard in hip and knee replacements, and then moved to Jacksonville. I've been in Jacksonville for 21 years. I've had the privilege of performing approximately 16,000 total hips and total knees. I have many, many patients out there in Jacksonville. It's wonderful to get to this stage in my career and walk through stores and neighborhoods and have people wave at me and remember me for hopefully helping them and taking their pain away. So it's been an honor to take care of all my patients. And if any of them are listening to me, I say hello to them all. Hopefully you'll learn some stuff. And for people who haven't met me, I look forward to meeting you in the future. So my first question that I put up, which is now quite interesting, is are knee replacements done in an outpatient setting or an inpatient setting? For the majority of my career, patients who had their knees replaced did spend time in the hospital. That has now changed in the last 2 to 3 years, and it's been a very interesting transition. When I was in training, which seems only a short time ago, but in fact it was more than 25 years ago, patients came in the night before surgery to the hospital, and they would spend on average 5 days after their knee replacements in the hospital before they would go home. We are now at the stage with our advancements that our younger, healthier patients or people without a lot of other medical problems can actually have surgery in the morning and go home to their house with very little help from a nurse's or doctor's perspective because they're doing so well. About 50% of our patients now who have their knees replaced are done in the hospital, and the other 50% are done in the hospital and go home the same day, or are done in a surgery center. And this has been a huge change in our practice in the last 2 years. It's been excellent for our patients. These patients go home the same day because they are ready to go home, not because they're being forced out. That's one of the concerns when people hear that. It's to do with our advancements that we'll cover in some of the other slides, but it really has changed our practice for the better for our patients. And obviously with the pandemic and the hospitals having issues over the last year, this has pushed us forward even faster. And if there's any questions on that, I'm sure this will be a topic that we might want to address in the questions and answer stage. Here's my most common conversation I have with patients. How long does it take to get over a knee replacement? So how it typically works is a patient will come in the morning. The surgery itself takes about 1 hour to perform. Like I just discussed, about half our patients go home the same day. The other patients will spend 1 or 2 nights in the hospital. Most people go home the next day. Some of our folks who need some extra care will spend a couple of days in the hospital and then go home after that. 100% of our patients go home. Again, previously, a lot of our patients used to go to rehab facilities. That's no longer required because the patients are doing so well. So everybody who has their surgery and has their knee replaced does go home. Most of our patients then go directly to outpatient physical therapy after that to get going with the rehab. Rehab is very important. We do a lot of preoperative rehabilitation, getting you in shape before surgery. And then obviously the effort comes from the patient after surgery. I tell people approximately by 6 weeks, you're 60% recovered. At 3 months, you're 80% recovered. It does take a year for complete, perfect recovery. It's a continuous process, but the majority of the healing is the first 2 months. So most people are back to most of their normal activities within 2 months. The third question, which is how much pain do people experience after surgery, is one of the biggest concerns that patients have. When we've done surveys of what people worry about, this is it. They're worried about the pain. Our pain control has really advanced in the last 5 years. One of the main reasons patients were in the hospital for a prolonged period, like we talked about, was we were not controlling their pain adequately. We have advanced this in many different ways to make it not that it's a pain-free surgery, but significantly less than it was. The preoperative physical therapy that everybody performs gets people in shape. So even if you have a very arthritic knee, we like to do rehab before. It loosens up the ligaments, it gets your muscles in better shapes and gets you prepared mentally for working out in the gym and in the therapy session. Spinal anesthetic is where they do a small injection into your back. It's just like a small IV. Your legs become numb for the 2 hours that you need to be numb and not feeling anything. And because of that, you don't need any of the heavy anesthetic medicines that we used to use. So when the spinal wears off, the surgery's over, you basically are feeling just like you were before. We also give you a lot of different types of medicines during surgery that really make you feel robust and healthy after it, so you can get up and do the physical therapy on the same day. The main medicines we use to keep you comfortable are Tylenol and anti-inflammatories, and we use narcotics sparingly, and they're used basically for breakthrough pain. So again, this combination of the spinal anesthetic, the physical therapy before and after, the very efficient surgery has led to us not having major problems with pain, and it really now is a very painless type of surgery. The next thing that patients worry about and ask about are the risks. Obviously, all surgery has risks. They are very small if it's knee replacements, but they're real. The problem with risks is if you get them, you're that percentage. However, the main ones to worry about, our biggest risk is an infection. It's extremely rare. We do a lot of things before surgery to optimize patients so they don't get an infection. Everybody gets screened for MRSA, which is the very strong type of staph. We will treat you and wash you if you are positive for that and give you different antibiotics around the time of surgery. We also have very clear protocols for people who are diabetic. We have to get their hemoglobin A1C, which is a marker of their diabetes control. We want that excellent before surgery, and we will delay surgery to allow them to work on that with their doctor to get their sugar levels well controlled. Obviously, the skin is very important. We do a lot of washes before surgery, the night before and the morning of, keeping the skin clean during surgery. And then we do very excellent closures, and we use special bandages now that stay on for a week after surgery, keeping the incision sterile in the postoperative period. My personal rate is approximately 1 in every 1,000 cases, which is still 1 too many, but it's very low. The national average is about 1 in 100 patients. Second thing that patients worry about is blood transfusion. Again, at the beginning of my practice, it was very common. We used to transfuse 50 to 60% of our patients because they bled so much in surgery. The surgical techniques have changed. We're using a special medicine called tranexamic acid, which has significantly decreased the bleeding during the surgery. So the good news is, over the last 9 years, I have not had any patient had a transfusion at all. And I do approximately 700 to 800 total joints every year. So this again has changed our practice, because obviously nobody wants to get a transfusion unless they don't require it. Unfortunately, this has not been achieved nationally. It's still approximately a 36% transfusion rate. And then the last thing, we do very thorough medical clearances before surgery. Knee replacement is a very important operation, but it is not an emergency. So we have time to work with your medical doctors, your primary care physicians, your cardiologists. We want everybody to be in as top of shape as they can be so they can come through the surgery and have success. And with these protocols that we put in place, we have a very low risk profile for knee replacements currently. This is also another common question. People often ask me, am I too old to have my knee replaced, or am I too young? The problem with knee replacements is there is no age limit. I guess it's not a problem. Knees hurt. Arthritis, which is the main reason for doing a knee replacement, is where the cartilage is worn down, it's bone on bone, and it's extremely painful. Whether you're 20 years old, 40 years old, or 80 years old, it still hurts the same. And if it's bone on bone, and we've tried all our non-operative treatment, knee replacements is recommended for these patients to alleviate their pain. So there is no age limit for knee replacement surgery. Many people, as they get older, worry incorrectly that they necessarily get sicker. Actually, most of my 80-year-old patients are some of the healthiest patients because they basically get into their 80s and late 80s and 90s. They're usually pretty healthy patients. So I don't hesitate to offer them surgery. Obviously, again, back to the medical clearances, we need clearances for our 80-year-olds as much as we do in our 40-year-olds. The oldest patient I've ever done an elective surgery on is 98 years old, and she did excellent. And the youngest patient I've ever replaced a knee for was 19 years old. But the majority of patients are on average between 55 and 80 years old who get their knees replaced currently. Here's an example of a patient I did a few years ago. She's 87 years old. If you look at the X-ray on the left of the screen, you can see her knee is worn out. She has what we call bone on bone. But if you see the white structure coming down, that's a rod. She had had a hip fracture prior to this 6 months before. And that was a big stress for this lady because if she broke her hip, it was an emergency surgery, and she still did very well. She came to me worried that she wouldn't be able to get through a knee replacement. I reassured her that an elective procedure where we can fine tune her medical clearances would be perfectly safe. We did her knee replacements and she cruised through it like most of my 87-year-old patients do. Patients sometimes ask me, are they too fat? As we all know in America, we are in an obesity crisis. 30% of Americans are obese. However, more than 60% of people having knee replacements are by definition obese. So it's a very common question in my practice. When your BMI, which is your body mass index, is over 40, these are the patients we do try very actively to get their weight down. If your BMI is over 40, it does increase your medical complications. The biggest one is infection, which is higher in patients who have surgery over this. So we try to get their BMI below 40 if possible. However, once patients who are overweight have their knees replaced and they don't have any initial complications, they actually do not wear their joints out quicker than somebody else. So once the joints are in there, they do last them just the same as everybody else. So obesity is something we discuss with our patients, but it's only in the morbidly obese when your BMI is over 40. This is my 7th question, but I think I hear about it from most patients. They want to know which implant company do I use. As we all know, we're all currently on the internet listening to me speak, if there's anybody out there. And the internet is used for marketing purposes. So all of the manufacturers now market directly to the consumer. Initially in orthopedics, the orthopedic companies used to market to the surgeons because the surgeons would choose, but now they go to the patients to try to influence the surgeon's choice of the implant used for the patient by going through the patients. The implant companies won't like me saying this, but I'll still share the actual reality that I share with my patients. So there are 3 major manufacturers in the world: Zimmer, DePuy, and Stryker. They each have approximately 30% of the market, making up 90%, and then the other 10% are made up of smaller companies. Each of these 3 companies are billion-dollar companies, so they're huge companies with a lot of marketing power, but also a lot of engineering and technical power. And the reality is, as we look at this picture, you cannot see any dramatically different differences between these implants. I tell my patients it's kind of like comparing luxury cars. Here's a Lexus, a Cadillac, and a Mercedes, and if you put them up on the screen like I did, in the same angle, in these pictures, they're all silver, they all have 4 wheels, and they all roughly cost the same. They're all very good cars. And even though each company will tell you that they're very, very different, if you look at them, they're also actually very similar, just like these implants that I choose. So the implants are important. The surgeons that you choose to do your surgery, they are the ones that choose the implants. All of the implants are high quality. In fact, just like the cars, they copy each other. So when one gets a little breakthrough in technology, very quickly soon after, the other implant companies will copy it. So the implant choice is important. I can spend hours talking about implants because I'm kind of like an implant nerd, or an implant, or if you had a car nerd, However, a luxury car is a luxury car, and knee replacement is like that. So don't get hung up with what type of car your surgeon drives, and let him choose the implant for you. Question 8. How long do total joints last? This is a very good question. It's a very common question, and it can be a confusing question. It's a bit like fake news is out there. What I guess I get asked more than anything is, Dr. Duffy, I heard that knee replacements only last 10 years. I've heard this my whole practice. This has always been incorrect, but it's out there in the world and it's very hard to unwind it. Here's what they're misquoting. When we do orthopedic research in knee replacement to look at the survivorship, which is how long they last, knee replacements have been and are so successful, we only do research every 5 years because nothing changes from year to year. Basically, they all keep doing so well. So when we do research, which I've done lots of in the past, we look at knee replacements at the 10-year mark, the 15-year mark, 20-year mark, and now 30-year mark. That's when we get the survivorship. So what the misquotation is, at 10 years in knee replacements done in patients now, 98% of them are still successful at 10 years, which is, if you look at it or think about it, extremely successful for any mechanical device. When we go out to 20 years, all comers, it's approximately 95% survivorship. How we get these numbers is we basically have a reunion. So you do a research protocol, you find people who had their knees replaced 20 years ago, you call them up, you ask them in for a checkup, look at their X-rays, and 95% of those patients will walk in with the knee replacement still functioning. So again, even if you listen to me say, oh, they last 20 years, no, 95% of them are functioning at 12 years. Now, the sad part is not everybody makes it for the 20-year reunion, because some people will have passed over that time frame. So they are now registered as successes because they went to their grave with their implant still in place. So the reality is that the vast majority of people who have their knees replaced, be they 40, 60, or 80, it will last them the rest of their life, which is really good news. Historically, one of the problems was knees would wear out. So it used to be not how many years, but how many miles. But with some of the new technology now that's been available now for the last 10 and 20 years, the implants themselves are not even wearing like they used to. So when I quote you a 20-year survivorship at 95%, remember that I'm looking at knees that were replaced 20 years ago, and the technology has continued to improve. However, having said all that, it's still very important to get regular checkups with your surgeon so they can take an X-ray and look inside your body and make sure that your knee replacement is still doing well. Once it's been replaced and everything has gone well, what sort of sports or activities can you get back to? Any sport is possible. I've had so many patients do so many different types of sports. Obviously, we live in Jacksonville. The most common is tennis and golf, hunting and fishing, but I've got people who've taken pictures on the ski slopes. I've got people who surf on my knees and ride horses, ride Harleys, you name it, they can do it. I let people know it's their knee replacement, they should take care of it. So I would not recommend motorbikes. Triathlon seems kind of crazy, and bungee jumping is a whole separate event. If you want to do something like that, I think whether you have a knee replaced or not is irrelevant. So I don't recommend these types of sports, but it would not be based on your knee being replaced. It would be based on me being an orthopedic surgeon and seeing the problems with some of these extreme sports. Work, any job is possible. We have no restrictions for work. Most people are back at an office type work at 4 to 6 weeks. 3 months, very physical jobs, military personnel, police officers, airline pilots, they're all back at full speed at 3 months. Question 10, which is my last question. This could be a whole talk in and of itself. What is the new technology out there? I'll again show my age. I've been doing this now in Jacksonville, like I said, for 21 years. When I was at Harvard for my fellowship, we released new type of plastic called highly cross-linked polyethylene. At the time, we were excited. The lab had been working on this at Harvard for many years and believed they'd cracked the code that had allowed the plastic not to wear out, which had been the Achilles heel of knee replacements and hip replacements. I still think of it as a new polyethylene. However, it is now 20 years old, and we have 20-year data that the new highly processing polyethylene has very, very little wear going on. So that has solved one of the major problems that we have with the original knee replacements. There's obviously now a lot of interest in the robotic knees. There's more and more switching to this as the technology, like anything, is improving. More and more knee replacements are being done with robot assistance. And then cementless technology, again, could be a separate talk. Historically, knee replacements have been held in place against the bone with the use of cement. Now, all of the companies have come out with new technology where the bone actually grows into the implant, like we've had in hips for years. And this really will, combined with the plastic not wearing out, the robot allowing us to place them in more precise methods, and the cementless technologies, makes a very, very successful operation even more successful. So thank you for listening. I'm not even sure how long that took me to go through that. We did on purpose leave some time for questions. I hope you learned something. That's a very good question. Physical therapy question or amounts depends on the patients. Like I said in part of the talk, we do have everybody do preoperative physical therapy. For somebody in reasonable condition, we typically do one session once a week for 4 weeks before, basically learning the exercises, getting a relationship with the physical therapy. Right after surgery, we do a lot of physical therapy. Again, it depends on how you respond. And so usually for the first week, we'll do it daily. Second week, we'll go to 3 times a week. And then depending on you and your therapist, once or twice a week, while you still do the therapy sessions yourself at home daily. So knee replacements are very successful, but obviously, like anything in life, things don't always go as well as we'd like. So if one of your knees is hurting, you should return to your surgeon. X-rays are obviously very important. Get examined and get a diagnosis. There's usually something we can treat. It does not necessarily mean that's a big problem, and does not necessarily mean that the implant's in trouble. You can still have tendonitis and pain around a knee replacement. When we replace a knee, what we replace is the cartilage, and the rest is still used. So you still have skin, ligaments, tendons that can cause pain that have nothing necessarily to do with the implant. But it would be worthwhile to go back to your surgeon, get it reviewed, and see what they think. No, that's used to be a common question. I do approximately 7 or 8 knee replacements in one day's work. So I could physically do 2 knee replacements. I could do your left one and then your right one. And some surgeons still do that. I've always disagreed with that. The medical complications is increased even in the best centers. And so I've never performed that myself. I typically do them about 3 months apart, because basically 3 months after the first one's fully healed up. There's also data that it's very hard to rehabilitate both knees. You basically have 2 surgically operated knees. So I did used to have partners who did that, and I saw their patients having a hard time getting on with their rehab. So I've never performed that in my 21 years in practice. I don't think it's a good idea, even though it's technically feasible. Like I discussed, age is important, but it's not a contraindication. The first thing is, how bad is your knee? So let's assume somebody's knee is very arthritic. Lots of people have issues with balance. We obviously want them safe to do some therapy, use a walker. But balance problems or neurological issues is not a reason not to do surgery. And being 90 is definitely not a reason not to do surgery. So again, that will be a case where I would meet you, evaluate the process, see if a knee replacement was even indicated, and then figure out how to take care of you with your balance problems. In the past, I've taken care of people with quite significant Parkinson's disease. I've done some patients who've had strokes on one side. They're challenging from a rehabilitation point of view, but you can still fix their knee. No, nobody needs a brace after a standard knee replacement. Your knee is good and strong that same day of surgery when you're up walking on it. You typically have a walker, mostly just to be safe because you had surgery that day. The incision is right down the middle of your knee. The length of it depends on the size of the patient. big muscular patients get bigger incisions, and small, dainty, skinny people get smaller incisions. But we still have to open up your knee and look inside to do the work. And the incision is closed either with staples or with glue, depending on the skin itself. Partial knee replacements are indicated if one specific part of the knee, typically the medial or inside compartment, is worn out. However, most people have arthritis throughout the rest of the knee, and therefore we require to replace the 3 compartments, which is the medial, lateral, and the patellofemoral, which people will call a total knee replacement. Yes, you're immediately weight bearing. You get up with support of a walker, but you're allowed to put as much weight as is comfortable on your leg. So it's remarkable how different people tolerate different amounts of arthritis. I see many patients who have very clear bone on their X-rays and who tell me the truth that it does not bother them that much. As long as you're functioning well and walking without an aid and your leg is not becoming particularly deformed, at a late stage, bone will actually significantly bow your leg or make you very knock-kneed. And if you get to a very extreme point, that can be a problem surgically, but we can still fix it. So pain is what drives us, pain and lack of limitation. So if you're functioning well, just because the X-ray says it's bone on bone does not mean you need to have surgery. There's no limitations of how many injections you can have. Unfortunately, what happens is the arthritis advances, so the injections stop working at a period of time. And again, I've been doing this for quite a while. I've seen people get 1 or 2 injections and then it doesn't work anymore. And occasionally people can have injections for years with no downside. So as long as the injections alleviate the pain, then we continue with those until they become not successful anymore. Everything going well, we see people at 1 week, 2 week, 6 weeks, and 3 months, and then 6 months and 1 year after that. So there's standard appointments that we give people, but obviously we're available if there's questions or concerns, and we see people constantly if need be, but typically 1, 2 weeks, 6 weeks, and 3 months. Like we discussed in the talk, there are many different manufacturers. They all have pros and cons. Currently, the knee replacement I use is made by DePuy, but I chose that for some technical reasons, and I use that in all my patients. So the implant companies all have high quality implants, and I use the one that I'm comfortable with, which currently is the Attune by DePuy. So Baker's cyst is swelling at the back of the knee due to the arthritic knee. We do evacuate that during surgery. We don't go back there and surgically debride it, but it is removed during surgery and all the fluid is taken out of it. So it's a team approach. It starts when you meet me and we decide to move ahead with surgery. We have binders with a lot of questions and answers that I've personally put together with my team that we give to our patients the day they book for surgery. I recommend that they read that, study that. It's a bit like doing some homework. There's no test for it, but a lot of the questions and answers in that. We have a preoperative appointment at Southeast Orthopedics where we go through a lot of things in detail as well. We also have a class both at the hospital and at the surgery center where you meet my special nurses who get to know you, walk you through that. So there's a lot of preoperative education to allow the surgery to go as well as can be expected. Correct. A lot of people have wearing of their arthritis on the inside of the knee or the medial compartment. That makes your legs bow out. During the surgical procedure, we do bony cuts to align your leg correctly and make it straight again. So people who come in very bow-legged will come out with straight legs. So there's different degrees of stiffness, but yes, people who become arthritic tend to become stiff. They have a harder time getting their motion back after surgery. In surgery, everybody's knees has a full range of motion. The problem is a lot of patients who are stiff before surgery will tend to drift back into that. So these are the people who really need to work hard in therapy before surgery to loosen it up and have to work very hard to fight that. But the majority of people will regain the motion that they've lost. that kind of goes back to the question about stiffness hyperextensions, where you're almost too flexible. So again, we would fix that in surgery and watch out for that in the postoperative period. Yes, everybody's knee replacement leg will be swollen directly after surgery. And it stays swollen for up to 3 to 6 months occasionally in some people. It's a continuous process. Obviously, it's more swollen at the start. And one of the things we do reinforce in people is to get their legs elevated, because if you can keep them elevated a lot in that first week or two, it stops the swelling. But even with that, people will notice their legs do swell for the first couple of months if they're up for a long time.